Healthcare is changing. It's changing in ways that many of us don't even know about, and it's changing in ways that all of us should be worried about. The change we should worry about is that healthcare has become more about disease than about people who sometimes have disease. And the practical effect of this is that as patients, we are often made to feel like just another number, labeled with a disease, rolling down a conveyor belt, where anonymous health professionals are the gears turning the belt. I'll describe several trends that are driving this change, offer some studies and patient stories to show how the change can be harmful to people, and conclude with some ideas about how we might lessen the negative impacts of this change. The trends that we're seeing today are a shift in the diseases that cause most of what we know as the burden of suffering. So increasingly, people are dying not of infectious or communicable diseases, but chronic diseases like cancer, diabetes, heart, and lung disease, which now represent more than 3 out of 4 deaths around the world in countries rich and poor. And so what we try to do is get out ahead of that by identifying people in the population that might have risk factors that would leave them vulnerable to these chronic diseases, such as obesity, smoking use, high blood pressure, and so on, because we're trying to prevent diabetes or heart disease down the road. And unfortunately for the patient, it sometimes means that they don't seem to get as much attention for their immediate problem today because the health system's more worried about the long-term costs and consequences of the population's health down the road. And consequently, what occurs is that we try to move back earlier and earlier the diagnosis of conditions so that we can intervene sooner. So what we do is we lower the threshold for diagnosing disease, and now we diagnose people with things like pre-diabetes and pre-hypertension in the hopes of avoiding or at least delaying diabetes and hypertension. But unfortunately, it doesn't seem thus far to make much of a difference. As one of my patients likes to remind me, life is a premortal condition. Because it's so expensive to provide care for chronic diseases which play out over years, our health systems are increasingly insisting on what's called value-based purchasing. Are we getting the value we want for the money we spend on health care? But it seems to me that the real question is, who decides value? Is it the patient? Is it the professional? Is it the policymakers? That's our challenge today. And to provide these increasing numbers of services to more and more people being found early on in their chronic diseases, what's happening in all around the world in every country is increasing market consolidation. So small groups get swallowed up into big groups, get swallowed up into systems, with the thinking being that that will make for a more efficient method of providing care. And patients get moved into what we call lines of service, service lines, by diabetes, by high blood pressure, by heart disease. Now, all of this depends on a science underneath it that has to be certain and correct. But in reality, as the bottom of the slide shows, our science is kind of uneven and somewhat suspect. And therein lies the rub. That's the problem that creates the conflict between the promise of population health and the reality of individual needs. So let's look at the evidence for a second, if that's what underlies all of this. What we do when we try to practice medicine is go out and get the best evidence available and turn those into clinical practice guidelines and measure our performance against those guidelines. But in point of fact, what occurs with time is that the evidence, as I'll show you in a moment, is kind of suspect. The guidelines increasingly become more and more disease-oriented and specialized, and the bureaucracies grow that are needed to measure and monitor performance. And that creates the problems that result in outcomes that none of us really want. So as you think about evidence, how good is it? Well, this was a study of studies. This looked at the most influential medical research studies in the world's literature. And what they found was that only 44% of the time, a little bit less than half the time, were these landmark studies' findings validated or confirmed by subsequent research. Thank you. And that is bad enough. I mean, it's scary enough that only about half the time will this study's results prove to be true. What's really scary is we don't know which half of the studies that's going to be true for. And so consequently, some have concluded that look at research validity, that when it comes to medical research, that most of the findings that are published are false. And it's because of things like improper study design or small or unrepresentative sample sizes, incorrect analysis of the data, bias due to industry influence or career reputations, and even outright fraud because of the desire to get published. And so the thing that we, I think, have to be very humble about is recognizing that when we take science at a population level, it's not very good, and when we try to apply it to an individual person, it's almost impossible. So for instance, I might say that if this study population showed a treatment death risk for this particular treatment of 1 person out of 1 million, that might be acceptable. But for the patient, if I'm that one, it's not so good. And when we get frustrated by the relative lack of relevance and validity of the usual research, then we fantasize that big data and supercomputers and machine learning will give us all the answers. And it doesn't. And we're terribly disappointed when Watson gets it wrong, as it does. So let's talk about this with some real examples. What should we do, for instance, in terms of setting a goal for blood pressure for a healthy older person? Well, in just the last 2 years, there have been 3 different sets of guidelines printed. And all 3 are different, and they can't all be right. But the choice that we make is quite important, because the difference between 150 systolic blood pressure and using medicine to push the person down to 130 systolic blood pressure, for some people that will mean that they get lightheaded, they faint, and they break their leg or their head. About a few years ago, I spoke at an international conference sponsored by the European Health Commission, and this is my paraphrase of the title. The title of the conference was basically, how can we get old people to do what we think they should do and save a bunch of money? And so there were several days of people standing up and talking about, well, we're going to get them to do better with their diabetes by changing their eating habits, by getting more exercise, by taking their medications as they should. So when it came my turn to present, I gave more recent literature that showed that if these speakers accomplished what they were setting out to accomplish and had these older people get what we call intensive glucose control, which is a hemoglobin A1C level of less than 7%. Hemoglobin A1C is a test we use to measure the average blood glucose or sugar over 3 months. That if they succeeded in getting all these Europeans with diabetes that were older under 7%, they would kill off 39,000 more each year. Now, maybe it came as a surprise to the experts, but it turns out that death is an important outcome for people with diabetes. Who knew, right? So I've talked so far about things like policies and populations and publications. But healthcare, of course, is very personal. And so I'd like to share 2 personal stories from patients of mine. The first I call the jarred journalist, and the second is the worrisome widower. About 5 years ago, I went into a consultation room with a journalist, and she was quite upset because the week before, she had received a telephone call from an unknown nurse in our very large organization. Now, I practiced in a group of 1,300 doctors with 7 hospitals and several dozen primary care clinics and specialty centers spread out over 500,000 square kilometers, all connected by a very sophisticated computer electronic health record. So a pretty big system. So this call came out of nowhere, and she was quite upset because the nurse said to her, "You need a colonoscopy to look for cancer of the colon." And there had been no advance notice to the doctors or the patients that a nurse was going to be calling to say this. There was no discussion about the other two tests you can use that are actually a bit safer and less expensive to look for colon cancer. And there was no awareness on this nurse's part that the journalist had a year before said to me, "My brother just died of colonoscopy complications, and I don't even want to talk about it until I'm ready." So during our visit, when she expressed her upset about the phone call, I turned the computer screen toward her, and I showed her that the previous year I had typed in, "Do not discuss colonoscopy unless she brings it up." And that seemed to help her upset a little bit. Now she's looking at the right side of the screen where there's a list of the services that our group's guideline says she should have. And at the top of the list it says colonoscopy. And this investigative journalist asks me, "Well, why does it just say colonoscopy and not at least include the other two tests that are possible to use?" She said, "Could it have anything to do with the fact that colonoscopy is the most expensive of the three tests and that your group just built a $23 million digestive health center and you have to pay for that?" In the 5 years since, so far as I know, she has not come back to our organization for her care. When we feel like we're the means to some organizational end, we lose trust. The second patient is an older gentleman. I'll call him Charlie. He's been widowed for several years. He's on a blood thinning medication that needs to have a monthly blood test. And for a number of years in our clinic, our nurse would do the blood test, immediately give the results to the patient, and then advise what to do in terms of adjusting the medication dose or not. Well, my large organization said along the way, "Oh, we're going to do something much more efficient. We're going to have all the primary care clinics send the blood specimens to the hospital, and we'll have the hospital pharmacist and that person's team call the patient the next day with the results." And I said, "Well, not here, you're not going to do that." And they said, "Well, why are you so special again?" And I said, "Because of my patient, Charlie." One afternoon, my nurse came in and said, "I just saw Charlie. His blood test is fine, but I've asked him to come in to see you tomorrow morning because something's just not right, and I'm not sure what it is." And so when I went in to see him the next morning, I didn't recognize him. He was sleep deprived. He was almost incoherent. He was having hallucinations that his dead wife would come to him at night asking him to join her. He was psychotic and suicidal. I admitted him to hospital. He was treated successfully. He's back at home doing very well now. And as I said to our organizational leadership, I said, "Look, your hospital pharmacist may know the chemistry of this blood thinning medication better than my nurse does, but the pharmacist doesn't know Charlie. She does, and she saved his life. More important than knowing the disease is knowing the person with the disease." There we go. So let's talk about something maybe a little less intense. We'll talk about transportation for a moment. Some days you may want to walk to the grocery or take your bike to the park or take the train to work. And for these common activities, we either manage on our own or we may sometimes turn to a trusted guide or advisor who knows us, our preferred mode of transport, things we'd like to see along the way, and who knows the local situation, all the dangerous turns or bumps in the road. On the other hand, if we wanted to take a rocket to the moon, we'd want a very large team of specialists with their guidelines and their checklists, just as we would want and expect if we were about to have a heart transplant. Yet most of the time, we just want to get to the grocery, ride our bike, and take the train to work. Most of us will never be on a rocket to the moon or have a heart transplant. And unfortunately, what's happening in healthcare is that every healthcare trip is being increasingly looked at as a rocket launch. Now, you might, for the moment, kind of say to yourself, "Well, all right, this sounds good, but have all these ideas really been tested in practice?" The answer is yes, they have. What some have called the largest public health experiment in human history has played out for nearly 15 years in the United Kingdom. It's called the Quality Outcomes Framework. And what happens there is that there are 135 measurements that doctors are actually paid more for when they achieve certain targets against those measurements, like blood pressure control and blood sugar control. And so nearly 15 years later, what have we learned from the QOF? That there's no decrease in premature mortality, that the improvements in the care process, how the care is given, do not sustain, they fade over time. There's no improvement in primary prevention. The care becomes fragmented and mechanistic, relationships get disrupted, and perhaps worst of all, the agenda for the patient can conflict with the agenda for QOF. And I've actually sat in on consultations where the patient says, "Doctor, you've got to help me with my elbow pain," and the doctor says, "Oh, no, we've got to deal with your blood pressure or blood glucose today." And so, as I say, some have said this has been a failed public health experiment. Where's the QOF at today? It's been dropped in Northern Ireland, Scotland, and Wales, and it's been scaled back significantly in England. So with what I've said today, you might conclude that, this guy really doesn't like colonoscopies or guidelines or counting things or measuring things. That's not true at all. It's simply that they're tools. They shouldn't become goals in and of themselves. They're just tools that help, hopefully, the patient achieve his or her health goals. Not my health goals for them, but ultimately his or her health goals. That, to me, is the challenge of healthcare going into the future. So let's remember always that each of us, throughout our life cycle, is a work of art. And around the world, we come in many colors. We have diverse experiences. We reflect or project different beliefs. And yet, if we focus only on counting brushstrokes or measuring pigment density, we'll have missed the essence and the beauty of that art. And so let's remember that healthcare is about people and about trusted therapeutic relationships. And let's, when we do measure, make sure that we're measuring things that really matter to patients. And if we have to count, let's always begin our count with the number one, the person before us.